Great. Hello, everybody. Hello, Adam. How's it going?
Hello, my friend.
It's good to see you. So, uh, bef let's get started. So let's talk about what we're going to be doing today. Firstly, let's make sure that everybody is already on the Telegram group. Um, Now, I've already shared the link on the Zoom chat as well. We will not be using the Zoom chat. I want everybody on the group so that we can see your questions, and you can ask us questions even after the webinar. So let us first introduce ourselves. So I am Z. My full name is Wei Zian Zito. I'm a GP working in London, and I've been with the NHS for the last 7 years. So I'm still working as a clinician. I still go into my clinics. I have experiences including obs and gynae for about 3 years, and I also train in palliative care and in A&E. I eat, sleep, and breathe PLAB. Every evening when I come back from clinic, I'm working on questions, on PLAB-related questions, on trying to make education easy for you all who are sitting for the PLAB exam. I founded Plabable back in 2016, and it's gone a long way from then until now. And with me today, I have my buddy, Adam Jakes.
Hi, everyone. So I'm Adam. I have worked with Z for many, many, many years. I've previously been a medical registrar back in the day, but I saw the light and the enjoyment of delivering babies, as well as how translatable it is to obs and gynae. So I'm a senior specialist registrar in obstetrics and gynecology. I also write questions on the medical topics. Me and Z developed the 4-day revision course, the biggest revision course for PLAB 1, which we'll talk to you more a little bit later. And together we also have developed more focused webinars such as ECG Masterclass and the most popular last-minute revision webinar. But as me and Z eat, breathe, sleep, think PLAB, we are keen to share our knowledge, help you with your revision, share tips and tricks, and hopefully you'll get an understanding and a taste of how me and Z teach PLAB.
Amazing. So as you all know, the PLAB exam has 180 questions. So you have roughly 1 minute to do each question. What we're going to be doing today is we're going to be going through some examples of questions, so you can practice on them. We also make sure we do some teaching on them as well. So let's get started with the very first question.
So
we'll give you a minute to answer.
We can launch a poll, right?
Yeah.
And what we do, we give you about 50 seconds, just like you would in a real exam, to give it a go. So make sure that you do choose an answer. Remember, there's no negative marking, and so you should answer all questions. A few more seconds on that. Amazing. So it's invariable that you will get some form of question on vaginal discharge, and actually it's relatively straightforward when you look for your clues. So this is bacterial vaginosis. You've normally got a gray kind of homogeneous discharge. It's fishy smelling, and they will also give you ideas such as clue cells, which are vaginal epithelium coated in bacteria. That's in comparison to trichomonas, which tends to give you frothy, non-smelly vaginal discharge. Chlamydia and gonorrhea are going to give you that green, yellow mucopurulent. discharge. Thrush is going to give you that vulval irritation and itching with the cottage cheese. And physiological discharge may be white, may be clear, but it doesn't cause any symptoms of itching, burning, soreness, or irritation. So what we've done and what we love at Plausible is a summary table. In fact, the majority of our course that we run is summary tables where we can chat you through them, but also give you something to take away and revise in your own time. So the management of bacterial vaginosis. So I've described it to you. I've showed you the science. In fact, I've even added the Amstel criteria for you to diagnose bacterial vaginosis, which is the typical discharge, an alkaline pH, and a fishy odor. The clue cells are the most sensitive, which I described in the question, but actually didn't give you the actual phrase. The diagnosis is made just on a vulvovaginal swab, and the treatment is metronidazole, usually topical intravaginal, which is safe in pregnancy. Other questions I've seen come up is, well, what causes bacterial vaginosis? Well, it's anything that disrupts the normal microbiome of the vagina, leading to reduction in your lactobacilli and an overgrowth in your Gardnerella. Yeah.
And then we move on to our next question. And I'll just launch the poll.
So a lot more mixed results here, Z.
Absolutely. I'll give them a bit more time because it's an epidemiology question. And epidemiology questions normally take a bit longer. So I'm just going to give you another 20 seconds. Great. And I'm stopping the poll here in 3, 2, 1. And in the poll, sharing the results. And here we have E as your answer. Now, epidemiology is a very difficult sort of category in the PLAB exam. And the reason behind this is it takes a lot of time to do it. So you got to make sure that you are prepared for epidemiology questions and don't think you can do them within 1 minute. All right, you cannot do them in 1 minute. If you think you can do it in 1 minute, you get frustrated. You know, for those of you watching me at home, you probably be banging your computers like this man here. Now, what we need to remember for this question is, firstly, what is the formula for numbers needed to treat? And that can be calculated by 1 divided by the absolute risk reduction, the ARR. So 1 divided by ARR. And everyone's going to ask me, how do you get ARR? So now we're going to think, how do we calculate ARR, right? ARR is the absolute risk in the control group, also known as ARC, subtracted by the absolute risk in the treatment group. So let's bring up the table. This is the table that you saw in the question, right? The absolute risk in the control group. How many people out of the entire people in the control group actually had developed SARS-CoV-2 virus? And that would be 20 out of 100, right? 0.2. 0.2 is your ARC. What about your ART? That would be 18 divided by the total amount which of people taking the new drug, which is 100, and that would be 0.18. So now all we need to do is get the difference, 0.2 minus 0.18, and you get 0.02. So now you have your ARR, not the numbers needed to treat, you got your ARR. Now all you need to do is 1 divided by the ARR, and you get your answer. 1 divided by 0.02, you get 50. Now, of course, you cannot bring your calculator in, right? You're not allowed to bring your calculator in for the PLAB exam. And so for those of you who find this calculation a bit too hard, 1 divided by 0.02, wow, what's the answer? I just cannot think about it. Then you just need to remember what you learned back when you were a student in school, right? That the two values can be times with whatever number you want, as long as it's the same number. So 1 times 100, 0.02 times 100, and then it makes it easier to count now. Now you have 100 over 2, which is 50. Much easier for those who are terrible at maths. So there you go. You need to know how to calculate numbers needed to treat. You need to know how to calculate ARR. You need to know what's the definition of numbers needed to treat as well. So what is numbers needed to treat? So going back at this, numbers needed to treat means that if I had 50 people taking this one new drug, I would have prevented 1 SARS infection. Sorry, SARS-CoV-2 viral infection. Yeah. 50 people need to take that one drug for 1 person to benefit. That is your numbers needed to treat. All right. So very difficult. Let's move on to the next question.
Okay. Well, you've broken everybody, Z, and so it's not very fair, is it, for you to melt someone's brain with the epidemiology and then we'll throw in some cardiology. But unfortunately, that's how the exam is. And so you may do plabable by topic, but actually the exam is so varied where you go from vaginal discharge, epidemiology to cardiology, and you've got to practice getting your brain into switching gears quite
Absolutely.
quickly. So let's do the poll. Oh, it's already up. Thank you, Z. Efficient today. Excellent. And people are zooming. And so we're just going to give 50 seconds just to get people going. It's fascinating that no matter what the question is, you will always get at least one person choosing every single answer. You know, there's never an answer which is so abnormal and crazy that someone doesn't pick it. Right, so let me just share this. But key thing here is that we've got a 56-year-old woman presenting to A&E with sudden onset shortness of breath and chest pain. Instantly you're thinking, is this pulmonary embolism? Is this pneumothorax? Is it pneumonia? Recently undergone an open myomectomy. Okay, so someone's had an operation. You're thinking, is this a pulmonary embolism? And has not been very mobile, with a high respiratory rate, low saturations, and the chest x-ray is normal. And so, yes, you suspect a pulmonary embolism, having ruled out a pneumonia and a pneumothorax with the chest x-ray. And then it says, what's the single most likely ECG finding? And it is sinus tachycardia by a long shot. And so those who chose S1, Q3, T3, it's a very rare phenomenon, particularly of a saddle or large pulmonary embolism. It is absolutely not the most likely. Sinus tachycardia is by far the most due to a physiological response to there being increased pressure within the pulmonary vasculature due to an embolism and thrombus. So sinus tachycardia, by far the most likely finding on the ECG. And then you'll ask me, well, how do you diagnose a pulmonary embolism? As soon as you suspect one, you should treat for with low molecular weight heparin, and then you arrange definitive testing. And in the non-pregnant population, a CTPA is your gold standard. It's a CT with contrast that allows you to directly visualize the thrombus within the pulmonary vasculature. The alternative is a ventilation perfusion scan, a VQ scan. But what you need is a normal chest X-ray with no respiratory disease, because if you're comparing perfusion to ventilation, well, there can't already be a mismatch. For example, if you have an abnormal chest X-ray, your ventilation part of your scan is likely to be abnormal prior to starting. And so you need to have no respiratory disease or chest X-ray. And it's reported as low, intermediate, or high. So Sod's law, if you get an intermediate result, then you may need to do further imaging like a CTPA anyway. But in the non-pregnant population, you're going to use a CTPA as your gold standard of diagnosis. And in a pregnancy population, what you're going to do is an ultrasound Doppler if there are signs of a DVT. If there's no signs of a DVT, no point doing a leg Doppler. Then you do a chest X-ray to rule out your differential diagnosis, such as pneumonia, pneumothorax, and then you will choose a VQ scan in the pregnant population. There's absolutely no guideline to suggest that you should choose a VQ over a CTPA. But a CTPA has much greater amounts of radiation to the maternal breasts compared to the baby, while a VQ scan has less radiation to the maternal breasts and more radiation to the fetus. And remember who your primary patient is, particularly when you're suspecting a PE in a pregnant woman, it is the woman herself. And so a VQ scan, although greater radiation to the breasts, less radiation to the breasts, but a slightly more increased radiation to the baby. But we're still talking about small amounts. And in essence, the most dangerous thing for any pregnancy would be a pulmonary embolism. So that's why if you get asked how to manage or investigate pulmonary embolism in pregnancy, it's a chest X-ray and then definitive testing, likely a VQ if the chest X-ray is normal.
All right, next question, everybody.
So take your time, guys.
All right, I'm going to stop the poll here in 3, 2, 1, and in the poll, sharing the results.
Excellent.
And B is your answer. You're going to repeat an ultrasound scan in 7 to 10 days. Now, firstly, let's think about this. Her gestational sac is small. Now, we don't expect to see cardiac activity with this size of a gestational sac, right? If the gestational sac was larger, let's say 25 millimeters or more, and you still don't see a fetal heartbeat, then you're thinking, oh no, this might be a non-viable pregnancy. But even then, you still need to do another ultrasound scan to confirm this, whether you get them to come back in a week's time to repeat this, or you get someone else to do the ultrasound scan. Now here, the gestational sac is way too small. It might be just that she's too early in the pregnancy to see a cardiac activity. So this is not something you're going to manage as a miscarriage. Now, one thing that the examiners like to do is put situations that are very unfair and not very much like reality. So here they give you an option of checking the beta HCG, which a lot of you put, but you have to understand how the examiner is writing the question. Firstly, the HCG is likely done already because it's normally done before you even scan the woman. So firstly, you got to think, okay, beta HCG is probably already done. Even if it's not done, does it serve any purpose? Right? Even if it's not done, a beta HCG probably wouldn't serve any purpose here. You know she's pregnant. A beta HCG at this point with one value is just going to tell you if she's pregnant or not. So here you would still pick a ultrasound in 7 to 10 days. Now, it's good practice for me to still do obstetric questions, even though I haven't been in obstetrics for many, many years now. And so, Adam, do you have anything to add on to?
I don't know why I let you
question?
do this one. Yeah. So I want you to be aware that this is quite a challenging question unless you've done gynecology before. But this is a pregnancy of unknown viability, right? We know it's in the uterus. Therefore, as Z says, a beta HCG is of absolutely no value. If I can see it in the uterus, yeah, then what is a beta HCG going to benefit in any way? You don't use a beta HCG to confirm a miscarriage, yeah? You confirm a miscarriage through size of the gestational sac, an assessment over time, and obviously symptoms as well. So when it is pregnancy of unknown viability, I can see it in the uterus, but I don't know if it's actually continuing. And so I'm going to repeat my scan in 7 to 10 days to see if it's growing. And therefore, I'll probably be able to see some fetal cardiac activity by that. Or it hasn't grown, and then you know it is just a static miscarriage. The beta HCG is useful when you have a pregnancy of unknown origin. Where on earth is that pregnancy? Because we know that the limit of identifying a pregnancy, particularly over abdominal imaging, like abdominal ultrasound, that's going to be a beta HCG of 1,500. Transvaginal, you probably will see something at around a beta HCG of 1,000. Yeah. And so if you cannot find the pregnancy, you assess the beta HCG to see where on earth it is. If you got a beta HCG of 2,000 and you can't see it in the uterus, that's a bad sign because it must be somewhere. Or if you get a beta HCG that's only 200, then what I'll do is I'll repeat it in 48 hours to see if it is if it's doubled or increased by 66%, suggestive of an ongoing pregnancy. Yeah. So don't get confused with pregnancy of unknown origin. Where on earth is the pregnancy? Do a beta HCG. If it's above 1,000, you can do a scan. If it's say below that, you would repeat it in 48 hours and see for that increase of 66%. If I know the pregnancy is in the uterus, but I don't know if it's alive or continuing, I'll repeat the scan in 7 days to see if there's been fetal growth. Right. So let me just give some more time and I will talk about, so you all need to know the nice guidelines for the management of hypertension, yeah, in and outside of pregnancy. And when you look at a question like this, answer it, but when you're practicing, also go through the drugs and say what class they are, how they work, and what are the side effects. For example, ramipril, ACE inhibitor, can cause dilatation of the efferent renal arteriole, can lead to acute renal or acute kidney disease, and first line for those who have proteinuria, renal disease, and hypertension. Bisoprolol is a beta blocker, can lead to bradycardia, hypotension. Amlodipine, a calcium channel blocker, you get leg swelling. Losartan, well, that's your your angiotensin receptor blocker, and indapamide is going to be your loop diuretic. So no, it's not. It's a bendroflumethiazide. Yeah. A thiazide, sorry. Anyway, so the other thing I mentioned is ramipril has a 10% risk of dry cough, doesn't it? So here we go. A 57-year-old Indian man, new diagnosis of hypertension. Okay, so I'm thinking Indian man, over 55, hypertension. The first thing you must always check if you're doing a hypertension question is you ask yourself, is there diabetes? And the next thing says, this person has diabetes. So as soon as you see diabetes, it trumps everything. Someone with diabetes should be offered an ACE inhibitor. The caveat to that is if you are Black Afro-Caribbean with diabetes, I would usually offer an ACE inhibitor, but instead I'm going to offer a angiotensin receptor blocker. Whenever you're meant to offer an ACE inhibitor, but they're Black Afro-Caribbean, you would offer an angiotensin receptor blocker in that population. So type 2 diabetic, instantly, I'm going to give an ACE inhibitor. And remember, the only ones that I don't in this context are Black Afro-Caribbean. So Indian does not fall into that criteria of Black Afro-Caribbean. If somebody is not diabetic, then the first thing you do is look at their age and ethnicity. So if someone's a white man under the age of 55, again, you're going to use an ACE inhibitor. If somebody's over the age of 55 or Black Afro-Caribbean, you'll use a calcium channel blocker first line. So really important, if someone's got diabetes of any type, type 1, type 2, instantly you say ACE inhibitor. If they're Black Afro-Caribbean, you're going to use an angiotensin receptor blocker. Yeah. And then those who are over 55, Black Afro-Caribbean, calcium channel blocker.
All right. Now, I think the gist here, and I just want to recap here, is you look at DEA, right, in terms of importance. D is your diabetes, right? The presence of diabetes trumps everything, like what Adam said. And then you have E, ethnicity. That would trump age, because if the patient is, African Caribbean, you'll be using a calcium channel blocker. And then lastly, you look at age. And age is where if you're younger than 55, you'll be using an ACE inhibitor. If you're 55 or older, you'll be using a calcium channel blocker. So Adam, you did a great job on this. Very, very good work. Good. So moving on.
Oh, I guess I have just a summary slide. So, when you go to bed tonight, you'll be hearing me saying fishy discharge, sinus tachycardia, CTPA, and diabetes gets ACE inhibitor unless you are Afro-Caribbean, therefore you get an ARB. ACE inhibitors completely safe in asthma. They do not cause bronchoconstriction. They cause a dry cough due to bradykinin release. And pregnancy, well, that's a totally different slide and conversation. But remember, labetalol is your first line, followed by nifedipine. But remember, we must never give a beta blocker or a beta and alpha blocker, such as labetalol, to an asthmatic. Really important that. So just like you wouldn't give a penicillin antibiotic to somebody who's allergic to penicillin, you do not give a beta blocker to an asthmatic.
Good. And then we have a next question here. I'm going to relaunch the poll. All right, I'm gonna stop the poll here in 3, 2, 1. Lovely. So I love this question here because it really shows Adam's true colors. Well, at least this Adam in the question, right? So here you have Adam who's working in the ward and he wants to date a 21-year-old girl. Now you challenge Adam that no, that's not appropriate because you've treated this woman, and he defends himself. He says, no, it's okay. I'm doing the right thing. And what do you do next? This is where you report to the lead consultant. You need to step up. You've already challenged Adam. He said he's doing fine. You don't then tell him again. You've told him once. The next step is to inform the lead consultant. You don't remind him. All right. You've done it once, move on. So, first thing is lesson to be learned. Adam here is always wrong, right? Adam is wrong. Now, it is inappropriate to start a relationship with a former patient that the professional relationship ended recently. So, in this case, Adam is wrong, but Adam is majority of the time correct.
99.9%.
Now, this is a screenshot of the show The Good Doctor, season 1, episode 17.
Spoilers ahead. Z spoils everything.
And I'm sure some of you might have watched The Good Doctor on Amazon Prime. If you had, you realize and you sort of scratch your head on this episode. Dr. Kalu is sort of treating this lady, which I can't remember her name, but I call her the tilapia scales lady because he's trying to graft something on her skin, which involves tilapia scales. Anyway, he falls in love with her and then he wants to ask her out, but she can't go out with him because she's his patient. So what he does next is he asks Dr. Murphy to take over her care so that he can now go out with her. Is that ethically correct? Right? Is that ethically correct? Definitely not. In the UK, that will not fly. I don't know why. In America, it's okay. At least in the movie, it seemed to be okay. Everyone was like, yeah, that's a great idea. But that's a terrible idea, all right? And it's not ethically correct. So do not date your patients. Patients who ask you out on Facebook, you say no. Former patient of which you are no longer treating, you say no. Attractive former patient of which you are no longer treated, doesn't change, it's still no. And patient who you met at a party which you treated 30 years ago, maybe. That's fine. I think there isn't a clear line in terms of when you can start dating someone you've treated. But if it's ended recently, if the professional relationship has ended recently, you should not. So 30 years later, I would say it's okay. Now we have our next question.
Right. Okay. So share the poll. Right, here we go. So here's the results. Quite a lot of people have gone for the same thing. So a 16-year-old girl comes in requesting emergency contraception. So you remember, emergency contraception is usually going to be, the first line is going to be the copper coil for anyone because of its efficiency. Her current sexual partner is a boy in her class. She does not want her parents to know she's sexually active. So this question is really testing you. Do you know the legal age for sexual intercourse in the UK? And actually, in the UK, you need to be 16 and over. So if you're over 16, you can have sex with anybody you want, as long as it's consensual. And so the answer here is live your best life, enjoy some sexy time, and prescribe emergency contraception. Yeah. So there's no need to contact police, safeguarding officer, or anything like that. And it's not illegal at 16. So remember, in the UK, you have to be 16 or over to consent to sexual intercourse. If the patient is between 13 and 16, you need to review your Fraser guidelines to see if they are Gillick competent. Be aware of anyone in a position of trust having sex with somebody between the age of 13 and 16. For example, a teacher, a carer, an after-school support worker, a doctor. So if this person who's 14 comes in and says, you know, I'm having sex, I'd like emergency contraception, but they are my teacher, actually, this is a red flag. And although you would still prescribe emergency contraception, the priority is contacting the local safeguarding officer and likely finding a place of safety for this child. Any sexual activity below the age of 13, so those who are 12 and under, it's a criminal offense. You don't ask any other questions and you make a quick child protection referral. So it doesn't matter if it's two 12-year-olds, doesn't matter if it's a 12 and a 15-year-old, any sex below the age of 13 is a criminal offense and instant referral to child protection. Now, as a doctor, you very, very rarely will contact the police directly. And this is one example of where actually the police is not usually the correct answer unless you believe that child is in danger this second. It's usually going to be contact your local safeguarding officer.
All right, so our next question then. All right, going to stop the poll in 3, 2, 1, ending the poll. Sharing the results. Ureteric stenting. So let's just go through the highlighted information on this question. This patient has a temperature. A CT-KUB shows a stone, shows hydronephrosis, and the creatinine is high. This patient has an acute kidney injury, likely from a stone. And he's septic, well, he's becoming septic as well. He's got a fever. Now, why are we doing a ureteric stent? A ureteric stent is one that we do to decompress the renal pelvis. You want the urine to come out as quickly as possible. So you have two options. You can either do a ureteric stent, which is where you normally do a JJ stent where one end goes out and then the other end goes all the way up to the renal pelvis. It's done under general anesthesia. Or you can do a percutaneous nephrostomy. And that's where you go through the skin of the patient. The interventional radiologists do this, and they go all the way to the renal pelvis, also to drain the urine. You need to drain the urine quickly, because if you leave the urine in for too long, he's going to get more septic and die. So that should be your first goal. You can think about removing the stone at a later day. You can put the tube in first, drain the urine, and once the urine's draining, right, there's no urgency. You can say, now that the urine's draining, I'm going to book this patient in for an elective procedure next week to remove the stone by percutaneous nephrolithotomy or any other procedure that you want to remove the stone, right? The important bit is you put a stent in first. That is the most important management. They will not well, I would say they're unlikely to give you ureteric stent and percutaneous nephrostomy, both in the same option, because it's very hard to distinguish which one to pick. Just remember, ureteric stentings are done under general anesthesia, and percutaneous nephrostomies are done by the interventional radiologist percutaneously. So when to pick ureteric stent and percutaneous nephrostomy? Again, I repeat, when you see a stone with obstructive uropathy, right? And a fever or an AKI. That's when you put a tube in to drain the urine. And then you remove the stone a week later. That way you're not using the emergency theater to try and remove a stone, which can be done electively, so that person waiting outside the theater with a AAA can live, right? He can come into the theater next. All right. So I want you to concentrate on the difference, because a lot of people make this mistake. Percutaneous nephrostomy is not the same as percutaneous nephrolithotomy. Ostomy means artificial opening. This is where a tube comes in to drain the urine. Lithotomy means surgical removal of the calculus. This can be done a week later, right? Do not make this mistake. And now we go on to our very next question.
Right. So what we have here, a 31-year-old woman presents to the infertility clinic with her husband. They've tried to conceive for 2 years. Periods are irregular, only 3 to 4 a year. The BMI is 32, and she has dark pigmentation, likely acanthus nigrans on the neck with severe acne. Getting laser hair removal for unwanted hair, and blood tests reveal a high LH and high testosterone level. So this is PCOS, isn't it? Polycystic ovarian syndrome, the most common endocrine disorder of young women. And so ultrasound pelvis to help you with the Rotterdam criteria. Salivary cortisol is for Cushing's. Semen analysis is obviously part of your fertility assessment, and prolactin would not give you your acanthus nigrans or changes in your LH. So the Rotterdam criteria, so to confirm polycystic ovarian syndrome, you need to demonstrate polyfollicular ovaries, anovulation or problems with ovulation physiology, and evidence of hyperandrogenism, like hirsutism and acne. Yeah, so 2 of the 3, you're able to diagnose the condition. Now, I just want to flag this up because people have struggled with it in the past. But metformin is unlikely to be the answer with PCOS management. In fact, the answer is going to be weight loss, weight loss, weight loss, a bit more weight loss, a little less cheeseburgers, and more weight loss. Because at the end of the day, this is a problem with your sex hormones. We know that estrogen can get converted to testosterone in the peripheral tissues, and it depends what your symptoms are. So if you have PCOS and you're struggling with irregular periods, I can offer to regulate those with either the combined oral contraceptive pill, progesterones, or even the Mirena coil. If it's fertility, like a patient before, again, weight loss, weight loss, weight loss, weight loss. And then we can offer to cause or stimulate ovulation with clomiphene. And the only time metformin is mentioned in the NICE guidelines is in addition to clomiphene, you can add metformin, but never metformin alone. Yeah. So you would only use metformin in the context of fertility with clomiphene, not for menstrual irregularity or anything like that. And I know it's common practice too, but it's not part of any national or UK guideline to use metformin, nor is it licensed in the UK for that indication.
Great. So we've reached halftime. We've got more questions coming up, but we wanted to talk to you about some other ways that you can prepare for your PLAB exam as well. So we've got a couple more questions after this halftime bit, but we just wanted to talk to you all about the 4-day revision course. Adam, walk us through it.
So the 4-day revision course is our baby, our child. We created it many years ago to optimize and ensure we're giving consistent advice about PLAB exam, because what you find, and I see it when you get close to the exam, people get stressed about conflicting information, and we found that was just causing stress and nobody was getting any benefit. And also there was no good revision courses to build a social network, to help people revise, to give resources to support them through their revision journey. So we developed a 4-day course, which comes with a big mock exam, a new mock exam written specifically for the course. We go through every topic known to man. It's me and Z teaching the majority of topics, but we also ask some specific specialists coming, such as our neurology senior registrar and acute medicine senior registrar, to talk about some of the juicy ones, such as stroke localization and arterial blood gas interpretation, because they found a really great way to teach that and to support candidates. So it is a paid course. You get to hang out with me and Z. It's normally a back and forth kind of jokes and playful banter, and it also allows you to build a social network where you'll be socializing and revising with those who are also sitting the exam. So it's an online course on Zoom, and we spend lots of time going off topic, giving you advice, giving you our tips, and getting you through the exam. And the next one's taking place on the 4th to the 7th of May.
Yes.
It comes with access to our WhatsApp groups, which are specific for the course only. You get access to me and Z for answering specific questions. It's not recorded because we want to make sure that it's interactive and you get the most out of it. And you get the full detailed lecture slides, which include significant summary slides that we've developed specifically for the course. The course also gets updated 4 times a year with any new guidance or any challenging topics that we hadn't covered in the past that came up in the previous exam. As I've already mentioned, we have very experienced neurology and acute medicine physician to come and talk to you about some of those really challenging topics, particularly neurology being the stroke localization, talking about MS and other complex and weird neurology.
Now,
I'll let Z talk about his question bank.
So the question bank, I'm sure all of you have already subscribed. You know, we've got about 3,400 questions. I think the one tip I want to give you all is don't just memorize the answers. Very often in the exam, you have 1 or 2 twisted stems. And for those who memorize the answers, you're going to get that wrong. But for those who truly understand the question and the explanation, those are the ones that are going to get it right. So it's the explanations you need to understand rather than just memorizing the questions. Now, I just want to state that in the course, we cover a number of topics which we believe are very important. And we always amend every course as well to fit the next exam. We want to try and target what we believe is going to be high yield for the next exam. So we hope you've taken off leave and you can make it for the course. But here are some other tips I want to hand you and make sure that you are aware of. If you are finished with the Plavable question bank and you want something else, there are some tips on looking at good question banks, right? You always want to look at what question bank is serving the UK at the moment. So look at the About Us page for a question bank. Are there any GMC registered doctors or not? Because that's going to determine if it's a good question bank. A lot of question banks out there are completely ripped off. So you just got to be careful with that. Are they actually updating the material? Next question is this question bank registered in the UK? Which means accepting pounds and not things like USD, for example. Why is this important? Because I get a lot of messages from you guys saying, you know what? I wish I didn't use this question bank. It's all completely outdated information. And then I'm telling people, yes, I know that. So make sure you choose the right question bank. If you do choose another question bank, outdated information is always going to be present in a question bank that copies material. That's because they don't have people to update their things. So coming back to a few bonus questions we have. All right, so everybody, let's get back to our studies. Let me relaunch the poll here. And I'll stop the poll here in 3, 2, 1, ending the poll. Sharing the results. Now, this is a very easy question now because we all know the importance of empagliflozin, or in general, any SGLT2 inhibitor. The use has become of great significance over the last few years because of the new research that shows that SGLT2 inhibitors are very useful for people with heart failure. So now if you have diabetes and you have any cardiovascular risk factors, we would smack you on an empagliflozin as well if your HbA1c is above the limit where we would want to start a medication. So here you have a patient who's already on 1 milligram twice daily, which is the maximum dose of metformin. 2 grams a day is the maximum dose, remember that. And so what you need to do next is crack on and start a SGLT2 inhibitor because his HbA1c is still not very well controlled. All right, a sulfonylurea, glycoside here, right, which is a sulfonylurea, is okay, but it's not going to help with his heart failure. In fact, it might make it even worse because he's got a BMI that's 31. And remember, sulfonylureas can cause weight gain. So you're increasing his weight, which could worsen his heart failure as well. So empagliflozin is the best. Pioglitazone should not be used in anyone with heart failure. It's contraindicated. So remember this one phrase: SGLT2 inhibitors are cardioprotective. And that's a new thing for you to remember. And then we come out to our very last question, which I'm relaunching a poll.
Excellent. So what we have here is a 17-year-old, 8 weeks pregnant with persistent nausea and vomiting, tachycardic, dehydrated, and continues to vomit. We've given sodium chloride with added potassium, which is the appropriate fluid to use. And we've already given our first line management, which is intramuscular cyclizine and buccal prochlorperazine. Now, remember that buccal can be used when someone's vomiting. It's very quickly absorbed. So you want to avoid oral medications, but buccal prochlorperazine is appropriate when someone's vomiting because of the fast action and quick absorption. So the next appropriate step is another line in your antihypertensives. Antiemetics, dear me. And it would be common practice to go straight for metoclopramide. But unfortunately, metoclopramide is relatively contraindicated in those under the age of 18 due to the risk of oculogyrate crisis, pseudo-Parkinsonism, your acute dystonic reactions. So metoclopramide should not be used in those under the age of 18. Therefore, you go to your next one, which is intravenous ondansetron. You'll never choose termination of pregnancy in the PLAB exam, and steroids would be your final step after having tried your Zines, your metoclopramide, and your ondansetron. So it's all based on the RCOG guidance. Remember, you want to use a crystalloid, adding potassium due to the loss of potassium with your vomiting. You're going to use your Zines, your cyclizine, your promethazines, your prochlorperazines, then your metoclopramide and your ondansetron, knowing that metoclopramide is relatively contraindicated below the age of 18. Steroids, unlikely to be the answer in the PLAB exam, but that is your third line. And then other things, you got to remember that if you are nutritionally deplete from persistent vomiting, there is a risk of developing Wernicke's encephalopathy, and therefore thiamine is offered, as well as the risk of neural tube defects if you aren't able to supplement your folic acid. And anybody who's pregnant has a higher risk of blood clots in the legs, the lungs, particularly if you're exacerbated by dehydration.
Lovely. Now, I just wanted to address something that I think a lot of you might be wondering in terms of how we give normal saline for hyperemesis. We tend to give it in a bag that's already pre-mixed with potassium, isn't it, Adam? And I think a lot of people are wondering this because, questions can be asked in such a way that they might have a patient with hyperemesis gravidarum, coming in with a potassium that's slightly lower, and they always ask things like, what's the next best step? Do you give potassium? Do you give thiamine, etc.? Right? And I think it's very difficult, but you should realize that sodium, the normal saline, for hyperemesis, we already pre-mix it with potassium. So that we should always be giving potassium for patients with hyperemesis gravidarum. All right, so that's the key thing: potassium, potassium, potassium. Don't miss that. Right, Adam? Anything you want to add on to that?
No, that's excellent. Yeah.
Lovely. So, guys, 1 hour. We are always on time. Now, we also just wanted to touch on what we have available at the moment. For those who are preparing for the May exam, these are the big mocks that we currently have. Of course, the big mock May is going to be part of the 4-day revision, which will be accessible to everybody after the course. But we will be doing the discussion of the big mock on the last day of the course, which is a big thing because now the course is a big course, right? The last course we had 599 people, and if you imagine what we started with when we first, Adam and I ran the first very course, we started with 2 people in our very first course, and that was a physical course, and now we've got 599 people. So we've come a long way, and I think we're doing the right thing because we're really trying to educate people, trying to learn from what you are weak at, and make sure we address them on the course. We'll be running WhatsApp groups, so it's much easier for us to answer questions on the course days. And of course, if you have any questions, we will still continue to answer them by typing it to you on Telegram. Now is the time that, when we switch off our cameras, then we'll read your questions and then we can answer them. It's all great fun in the course, and it's just fun times. Adam, anything else you want to add on to this?
No, I mean, the big mock is us spending a long time writing new questions that are not on the Plabbable question bank. And the reason for that is because the Plabbable question bank is essential. It's an amazing resource, but because everyone has done it, you become familiar with the questions, and therefore it's amazing at building up your knowledge and getting you ready for the exam. But what it doesn't do is show you how you respond to never before seen questions. Yes, because you can get used to muscle memory and just saying, oh yes, I remember this question. The answer is this. And in the PLAB exam, sometimes they just tinker with question vignettes rather than change it. And so us, by writing 180 new questions, you really get to challenge yourself, particularly if you do it in exam conditions. And feedback from candidates has said that the big mock exam is very similar in difficulty and how it feels compared to the real exam. And therefore, it's not unreasonable to suggest that a good passing score in the big mock sets you up to have a good chance of passing the real exam.
Amazing, guys. So it was great to have all of you join our webinar. And we will hope to see you in the UK one day, or if not, on the course with us. Thanks, everybody, for joining us. And we wish you all the best for your exam. Adam, last words?
Hope to see you soon, guys. Yeah.
All right. All right, everybody. Bye for now.